I think most of us here don't really need an introduction to Abhishek, but just in case, I will give a very short, brief one. So Abhishek is a DPhil scholar at the University of Oxford, and he is primarily focusing on the ethical, legal, and policy issues arising from the use of AI systems in healthcare. And today in particular, he is going to be presenting on whether reliance on black box AI can compromise shared decision-making. So over to you, Abhishek.
Thank you, Mathavi. So I'll just start sharing the screen. Can everyone see this? Okay, so I'll just jump right into it. Like Matthew said, I'm going to talk about whether reliance on AI can compromise shared decision-making. And just to be a little bit more specific, the question that I'm going to be looking at is, to what extent would the use of black box AI models in clinical setting compromise the ideals of shared decision-making both now and in the future? Now, there's been a lot of debate around the use of black box AI models in critical domains like healthcare. And these questions around the opacity of these models focus on both epistemic issues. So, for instance, to what extent can these models be used well by the physicians? To what extent are opaque models useful as far as can they allow us to reach as good clinical judgments as transparent models, for instance? There's also issues around ethics. So questions around how will we adjudicate responsibility? How would we look at questions around accountability? I'm going to put all of those questions aside, and the focus today is primarily just going to be on shared decision-making and to what extent opaque models compromises or supports or can exist compatibly with shared decision-making. So generally in the literature, there are two major ways in which these sorts of opaque models are claimed to compromise shared decision-making. The first claim is that they do not allow us to access, or they do not provide us with the medical explanations for their recommendations, which are critical for shared decision-making. And the second claim is that they risk excluding important patient values and preferences from these clinical decisions. And the idea is that when these patient values and preferences are excluded, this diminishes patient autonomy, self-deliberation, and through that undermines shared decision-making. Now, there's a lot here, and I'm going to unpack it slowly over the presentation, but this, I think, is a good frame for how we're going to think about these issues. Just to take you through how I'm going to be structuring the presentation, I'm going to start off talking a little bit about AI in healthcare. What are the use cases, very, very briefly, but also importantly, what do we mean by black box AI? What do we mean by interpretable AI? What do we mean by explainable AI? How do these differ? I'm going to also then very briefly talk about shared decision-making and the various models of shared decision-making. Not going to spend too much time on that because I'm assuming a lot of us are already familiar with it. And then we're going to get to the meat of the talk, which is looking at those two challenges that I had just stated, which I call the medical explanation challenge and the value congruence challenge. I'm going to present the main arguments presented in the literature, and then I'm going to see to what extent they work. And that's going to be the presentation. So I think at this point, we don't really need to talk too much about AI in healthcare. It's pretty pervasive. And it's pervasive across the healthcare spectrum. So it's used in medical research, in drug discovery, in clinical use, in patient engagement, all of this. And specifically for the purposes of this presentation, we're going to be looking at it primarily for clinical use. So we're looking at things like predicting health outcomes, helping with diagnosis, helping with treatment recommendations, and so on. But what do we actually mean when we say black box, and what is black box and what is not black box? Sorry, this slide seems to be moving forward on its own. Anyway, so when we think about black box AI, what we're really talking about is deep neural networks. Now, these are extremely complex neural networks that consist of multiple layers in between the data that is provided for a decision to be made on and the classification or regression output, or sorry, I'm not sure why this is moving along. Just give me 1 second. Yeah. So many layers in between the data input and the classification. And essentially what it is characterized by is this high dimensional optimization. So sorry, just give me 1 second. Not quite sure why it's. Apologies, 1 second. Okay, hopefully this works better. Yeah, so many layers in between the input and the output. And yeah, there are basically a lot of variables that are being optimized. Okay, this is obviously not working. 1 second. I'm just going to present in non-presentation mode. Right. So high dimensional optimization by the model, there are many layers in between the input and the output. Essentially, there are so many variables that are being considered by the model that if we try and understand as humans all the relevant variables that the model is using to make a recommendation, we won't be able to fully sort of imagine and capture all the relevant pieces. So the only sort of explanation that we can get with black box models is our statistical explanations. So past track record for how the model has performed, what are the subgroups that the model has been trained on, what are the various rates of performance across the different training and so on. So this is what we mean by black box AI. On the other hand, we have two cases where the sort of box can be opened up. So one is by using what is known as interpretable AI models. So these are models where the overall complexity of the model is constrained. So these are not deep neural networks, but somewhat simpler models. And the model complexity is constrained so that the reasoning can be understood by humans. The model is making inferences on a much more finite set of variables, and these variables can be captured and understood by humans as compared to deep learning models. And the key advantage here really is that by inspecting these various parameters or features of the model, you can understand how the model has reasoned to produce the classification. So importantly, interpretable AI is restricting complexity of the model. On the other hand, explainable AI is looking at using a secondary interpretable model to explain the decisions of the primary model that is making the classification. So we can think about a deep neural network, which is completely black box, which is used to make these different classifications. And then we can think about a secondary model that then provides a best guess for why the first model is making the relevant classification. The reason why this debate even exists about whether shared decision making is compromised or whether opacity is problematic is because there is a purported trade-off between accuracy and interpretability when it comes to these models. So traditionally speaking, because for black box AI models, we are not restricting the complexity of the model, they are argued to be more accurate overall as compared to interpretable models, which although are explainable, but because they are simpler, they're less accurate. Although this is a contested claim, we're going to take that as an assumption moving forward. So with that understanding of black box and interpretable and explainable AI, let's quickly look at shared decision making. So shared decision making is important for patient autonomy. There have been various models that have been put forward over the last 30, 40 years. It's an issue that has been written about a fair bit. But the key elements really are as follows. So you have a two-way information flow between the doctor and the patient. The doctor provides the medical expertise, the patient provides the trait values and preferences for the medical decision. Importantly, these values and preferences are not treated as fixed and known by the patient. More nuanced understandings of shared decision-making look at these values and preferences as sometimes requiring reconstruction within the clinical setting. And at the same time, as you want to feature the patient's values and preferences, you also don't want to leave them without support in the moment of the clinical decision. You don't want them to feel like the entire decision rests on them if they feel like they're not able to get to adequately make that decision without support. And so you don't want just a system where the doctor provides medical expertise and tells the patient, pick whatever decision you want. You want the doctor to support the patient. And sometimes there is scope for the doctor to advocate health-related values. For instance, telling the patient, perhaps you should reduce smoking, perhaps you should eat foods lower in cholesterol, and so on, even if that might not be what the patient's primary end for themselves is. So these are the main sort of features of shared decision-making models. And I think it's helpful to think about this less as necessary and sufficient conditions, more as a family of models or a family of approaches that share these different features. So as we had looked at earlier in the presentation, there are two main ways in which the black box AI models are claimed to compromise shared decision-making. And I'm going to call it the first way, the medical explanation challenge, in that these models do not provide us with medical explanations, and somehow these explanations are important for autonomy and shared decision-making. And the second as the value congruence challenge, which is that these models risk excluding important patient values and preferences. So we're going to look at each of these challenges in turn. So the medical explanation challenge. I think this has been posed by quite a few commentators in the literature. And if you were to abstract away from the specific features of each of the arguments as they pose them, this is the general structure of the argument as it comes across. So the argument is that shared decision-making requires that the patient be informed of all the information relevant to the medical decision at hand. And unfortunately, the use of black box AI models does not allow the patient to access the medical explanation for how that diagnosis or treatment recommendation is reached. And considering that medical explanations of these sorts are information that is relevant to the patient, the argument is that we are not able to meet the requirements of shared decision making with these models. So just to unpack this a little bit, what exactly do we mean by a medical explanation? So these are mechanistic causal explanations that invoke medical concepts, and you can think about these explanations as ones which we typically receive in non-AI clinical settings. So for example, a patient may be told that they have persistent anemia. The most likely cause of persistent anemia for them is a pre-existing gastrointestinal condition. This was a condition that was dormant. It causes ulcerations in the intestines, but it became reactive after the patient had a cardiac event and was given, say, antiplatelets. So there is a clear evidential chain of reasoning. So we move from the evidence at hand to what this indicates about the best possible hypothesis about the patient's psychological state and what this psychological state might cause, physiological state might cause, and therefore what the diagnosis would be and how this confirms the evidence. And these medical explanations are seen as by many commentators as crucial for shared decision-making. They require that patients are able to comprehend and process rationally these medical explanations. The absence of these medical explanations can be seen as not meeting the requirements of informed consent and so on. But I want to look at that, and I want to sort of challenge how important these medical explanations are really. And I think in order to do that, we can look at two models of patients in the clinical setting. So the first model is looking at patients as passive recipients of medical expertise. So patients who might not be able to fully engage with medical explanations that are given to them by doctors, even in non-AI settings. So in most cases, when a medical explanation is conveyed to them, patients might be able to register certain facts about their physiological or biological states, or about the medical or drug knowledge that is imparted to them. And they might be able to follow along the chain of reasoning and inferences as the doctor presents it to them. What they might not be able to do is to epistemically evaluate whether this medical explanation is the right one. Is it a reliable one? And is the medical explanation, does the medical explanation allow them to assess whether the physician is actually making the right decision as far as their treatment or diagnosis is concerned? So they're not able to utilize this explanation to themselves reason about what the diagnosis or treatment should be. And under such a model of patient behavior, medical explanations are seen as causally superfluous to their deliberation, and they don't enhance their, they can't be said to enhance their autonomy. If we understand enhancing autonomy as either increasing the number of options that are available to these patients or allowing them to reason better over the options that already exist. Now, we can contrast this with other information that allows patients to participate more in the decision-making process and to, better serve their autonomy. And this is information around treatment alternatives, around prognosis, around risks and benefits that they face in the decision at hand, and so on. And I think this is reflected in existing clinical measures of shared decision making. So if we take a look at various clinical measures such as the option scale, the decision conflict scale, and so on, what is really prioritized is whether the patient has the knowledge about what the treatment options are, what the alternatives are, what the risks and benefits are, and so on. And this is important because the patient can use this information to reason about which treatment is better for them. And this sort of falls under, allowing patients to act more autonomously. So under this model of a patient, we can see that premise 3 is false because medical explanation for how diagnostic or treatment recommendations was reached is not really information relevant to the patient as far as their autonomy is concerned. So that's one model of patient behavior in the clinical setting. But recently, over the last 10, 15 years, we have another model that has come out. And this treats patients as active, autonomous, and competent inquirers and epistemic agents in the clinical setting. So there has been a proliferation of alternative sources of medical information, explanations that have been provided outside of the clinical setting that patients are able to engage with. And patients are able to learn from this and take this knowledge and this understanding to the clinic and engage and evaluate medical explanations within the clinic as well. So the question is, well, for these patients, are there, if a medical explanation is not provided, are there autonomy gains left on the table? And I think perhaps there might be, but I don't think this is necessarily a deep problem, because these autonomy gains can also be achieved through alternative explanations. So if patients are instead provided with statistical explanations, if it's a black box model, so they're provided with explanations around how what the model's track record has been in recommending the different treatments, who are the patients this model has been trained on, what have been the relative rates of model performance across different groups of patients. This is also information that patients can potentially use to reason better about how reliable the model's performance actually is, and whether the options open to them are as the physician or the model says they are, and how can they reason about these different options presented to them. So in the case of black box models, you can still have statistical explanations that patients can engage with. And in the case of, if there is a secondary explainable explanation model that explains the decisions of the black box model, or if you even just have the doctors using these models hazarding a best guess explanation for why the models are behaving in a certain way, you can also use those best guess explanations to think about, to what extent the model could be making the right or wrong decision. So even if we treat patients as active epistemic agents who are able to assess different explanations, we still have the option of these patients using alternative explanations instead of medical explanations to further, to better serve or to participate more autonomously in the decision process. Of course, this is not something that they've so far been trained on, but I think the idea here is that in the way that they have been able to train themselves on medical explanations and which medical explanations are correct and not, and what medical facts of the matter are correct and not, you can also do so for these alternative other explanations. There's a slight wrinkle here, though, because so far we've been treating medical explanations as important only so far as they causally affect a patient's decision-making process. But we can think about what happens if shared decision-making requires information that doesn't have a causal impact on the patient. So I think this coincides with what is known in the field as broader conceptions of shared decision making. So conceptions where it's not just about whether it makes a difference to the patient's decision at the end of the day, but whether there can be information that is material to a patient's deliberation, even if it makes no causal difference to the outcome. So I think one way to think about this, for instance, is a pregnant woman might want to know about the implications of a C-section delivery in terms of the length and placement of the incision, the expected level of post-operative pain, the discomfort, and so on. And this is information that she would like to have, for instance, even if it doesn't actually change her decision about how to proceed. And so this has been noted to be in the literature as information that is still material to a patient's deliberation, even if it doesn't causally affect it. And so perhaps medical explanations are information of this sort. They're material even though they don't causally affect. And so therefore they are still important in broader conceptions of shared decision making. And what makes them material is that patients consider them material. So it's so there are no other conditions here that qualify. I think this sort of approach is intuitively compelling. I can see that medical explanations might indeed provide the sort of information that patients might be glad to possess, knowledge about the various physiological events happening within their body and so on. And perhaps statistical explanations might not serve the same purpose. And even best guess medical explanations might work, but compared to bona fide medical explanations, they might not be seen as quite as material by the patients. And so I think this argument is intuitively compelling, but I think ultimately it is an empirical question. So the question really is, do patients consider medical explanations to be material in a way that statistical explanations, best guess explanations are not? And I think this requires some level of empirical research to figure out. So that was looking at the first challenge. We're going to very briefly look at the second one as well. And if you recall, the value congruence challenge was that these models risk excluding important patient values and preferences from important clinical decisions. And this in turn diminishes patient autonomy and undermines shared decision making. So when it comes to the discussion of this challenge, there are two main claims which I've made in the literature. So the first claim is that these systems that recommend treatments for patients don't necessarily factor in the patient's values and preferences, as they're built to function for a large number of patients. And this is especially so if the treatment choice is preference sensitive. So for instance, if there is no clear, there's no clear treatment between two competing treatment options, both are medically effective, and it just depends on what sort of life the patient wants to live and what sort of preferences the patient has about the outcomes from the treatment. And the second claim really is that this problem is further exacerbated if the AI system is opaque or black box. So opaque systems do not allow scrutiny of the decision-making process. And in sort of hiding this decision-making process, they might prevent doctors and patients from seeing the recommendation of these models as value-laden at all. And so one example of something like this might be, this thing of this model that was used in the field called Watson for oncology. This was a few years ago. This model was used to develop recommendations for cancer treatment, and the model would rank treatment options based on how well they would maximize the lifespan of the patient. And this particular priority of maximizing lifespan was not something that could be adjusted for a particular patient. So for instance, if a patient wanted to make a decision not based on how much their lifespan would improve, but based on the extent of morbidity they would encounter as part of the recovery process or after the intervention, this is not something that could be adjusted within the model itself. And in fact, when it came to these models, the fact that this particular value was used to prioritize treatment rankings that were provided wasn't even mentioned in the documentation that was given out to the doctors. And so commentators in the literature have talked about how this does not encourage doctors and patients to view decision-making as value-laden. And what is really needed are AI systems which are value flexible by design. So these are systems which are designed in a way that they're able to select and use different values depending on what the patient prefers and generate rankings based on that. So this is something where models need to now be designed in this way. And it's no longer enough that a single value, or not that it's no longer enough, but it was never okay for a single value to drive overall treatment decision making. So I think one way to look at this is to think about how good the model is that we're looking at. And we can think about two types of models. We can think about models where the performance is comparable to or inferior to the human using these models. And we can think about models where the performance is significantly superior to humans using these models. Now, when it comes to performance when it comes to models which perform comparably or not as well as humans, I think value congruence, as far as shared decision-making is concerned, requires value flexibility in the overall clinical decision-making system. One way to get that value flexibility is to make sure that each part of that system is value flexible, but that's not the only way. We might allow AI systems to not be value flexible, but as long as doctors are aware of the fact that there are certain value judgments that are driving treatment rankings, for instance, these rankings can then be reordered later on. So if a patient comes to a doctor and says, in the case of Watson for oncology, if a patient comes and says, you know, what matters to me less is how long I live after the intervention. What matters to me more is the quality of life that I will have. The doctor can look at the model's recommendation, reason over it, figure out that if we want to look at minimizing morbidity, the treatment rankings need to be different, and then present those adjusted rankings to the patient as treatment alternatives. So, of course, this still requires the doctor to understand in a particular medical situation that there are value judgments that are going to be driving the treatment decision. But as long as this prior work is done by the doctor or by the model developers and communicated to the doctor, I think even models which are not value flexible can still ultimately allow for value flexibility in the overall clinical situation. But I think that the situation is a little bit different if the model performance is significantly superior to humans using it. Either because the tasks are such that no single human can actually perform them. For instance, we have kidney exchange algorithms where pairs of individuals, one who needs a kidney and one who has a kidney to offer but that kidney doesn't suit the individual that they are coming along with. These pairs of individuals can plug into the system, and you can have an optimization done through algorithms that allows for the best possible selection of kidney exchange. Now, these sorts of computational tasks are too complex for humans, and algorithms have been used for them for the last 10, 15 years already. So you can imagine that in such a situation, the doctor might not be able to reorder the ranking based on a different set of values, because that would require the doctor to solve the computational task all over on their own. And given that these models are better than humans at solving these tasks, the doctor might probably do a worse job of ultimately allocating, for instance, kidneys across different pairs. Or you might even think about it from the perspective of models which are significantly better than humans in clinical settings. So right now, if you look at, for instance, image classification models for chest X-rays or radiological models in general, the best models are about comparable to humans. But we can imagine 5 or 10 years later, these models are significantly better than humans. And so if a human interferes with the model's recommendation, there's a chance that the human would make the recommendations ultimately worse off, medically speaking, for the patient. So I think under such conditions, value flexible systems make complete sense. You don't want someone else who is an inferior medical operator to be tweaking the model's recommendations just to ensure that different values are represented in the ultimate treatment recommendation. And so I think value flexibility is important, but I think what is less appreciated here is that value flexibility does not require interpretable or transparent models. So I think there are ways through which value flexibility can be instantiated even in black box models. One example of it, for instance, can be such that in the training stage of these models, each piece of training data receives multiple labels where they initially received only one. So for instance, if you have a set of evidence relevant to cancer, it can receive a label for what the intervention should be if the patient is concerned with maximizing lifespan versus another label for what the intervention should be if the patient is concerned with minimizing morbidity. And this can then feature into the overall machine learning approach. The models can reason then and learn over these dual labels rather than single labels. There's been less research on this so far, and in fact, it might just turn out that it might ultimately be easier with interpretable models than not. This is the question that I don't have a very set opinion on right now, and probably more research is required. So I think, yeah, I think there can be other questions around shared decision making as well. But I think here I've tried to answer or address the two main questions that have been put forward in the literature. And I think my general takeaway from this is that there are certain edge cases in which shared decision perhaps might be compromised by black box models, especially so in the future. But I think the overall concern is overstated in the literature. I think there are ways in which we can preserve autonomous participation for patients, preserve shared decision making between doctors and patients, even with the use of these opaque models. And I think that's the end of my talk. Thank you.
Thank you so much, Abhishek. That was quite a lot of detailed information in quite a short span of time. So maybe we can open up the floor for discussions and questions. I think Murali has the first question. You're on mute, Murali.
Okay. Hi, Abhishek. Like the talk, just have something in the realm of objection. You see how serious it might be, right? So at least, so of course you're looking at shared decision making, and at least until you looked at it in terms of shared between the patient and the physician, at least prior to that, I was thinking of it in terms of physician to physician. That means that, for example, in a lot of hospital settings, you don't necessarily have one physician treating the same patient all the time. The patient sees whichever physician is on call or is available. And usually there are patient notes, and physicians look at the patient notes, the case notes, to see what previous physicians have recommended for the patient and what to do going forward, right? And crucial to this kind of decision-making process is these kinds of medical explanations, because each physician needs to know what's the rationale for the previous physician's decisions, and whether that rationale makes sense given given what the patient's current symptoms, or given the patient's previous symptoms, and so on and so forth. So there's a kind of showing your working that's going on here that would not be possible if in a complete black box AI.
Yeah, I agree. So two responses to that. The first response to that is that's a concern for the ways in which black box AI models frustrate epistemic goals. it's not a question for how they frustrate shared decision-making goals.
Okay.
And because what we're concerned with is, or what you're concerned with in this case is other doctors, for instance, being able to reason better and produce better clinical judgments based on medical explanations that have been provided to them for the decisions of prior doctors. And so this is important. And I think it's an open question really about to what extent these medical explanations are important for producing better and more accurate clinical judgments. I personally think that there might be alternatives, but I do agree that the default approach is that these medical explanations are important for epistemic ends. So I think I agree with you that they're important for epistemic ends. For the purposes of this talk, I was sort of bracketing away epistemic concerns, and I was looking primarily at shared decision-making concerns. The other response I have to you is also that, well, you can get medical explanations or something close to it, even with black box AI models, by using explainable systems. So you can have best guess explanations that are provided based on the use of these other models, or you can have the doctor, for instance, making their own guesses about why the model is performing in the way that they are. For instance, if the model's recommendation is in line with what the doctor would have independently recommended. I agree that this is not as good as bona fide medical explanations that are actually how the model reasoned, but I think to some extent, perhaps this can suffice as well. But yeah, I think I'm still open to the possibility that it's important for epistemic ends, but I think shared decision making in general, I think maybe not so much.
Okay. Thanks.
I think Prof. Savulescu is next up.
Yeah, thanks, Abhishek. I thought that was fantastic. So one comment and one question. So I really like the way that you sort of diffuse the value of medical explanation to sort of autonomy. And I thought you could strengthen that by sort of pointing out that ultimately, at least when it comes to treatments, all doctors are appealing to are statistical associations. So you could use the statin example that they don't really know how they work. They just know there's a statistical association with improved survival. They started off with an apparent physiological explanation, which turned out to be junk. So I thought you could strengthen that even more. But my question is this: the thing I took away was that what we really need to know about AI is what value it's maximizing. So in the Watson model, you need to know that it's maximizing length of life. And when you know that, then you can adjust the recommendations. The doctor can say, well, look, it recommends A, but actually B will give you better quality of life. So if that's more important, go for B. So I didn't understand the problem with the kidney exchange, because that seemed to be exactly the same. So, what kidney exchange is doing is maximizing the compatibility between organs. So essentially maximizing survival of the kidney. So it'll come up with a recommendation, patients A, B, C, D in that order. But say you want to take into account responsibility. Well, then you just take that ranking and you go, oh, well, actually C is the least responsible and deserves the kidney, and it's still the third most compatible, organ. So I didn't see why doctors couldn't use other values in the kidney exchange model in just the same way as they did with the Watson model.
Yeah, so that's a good question. So I think with the kidney exchange algorithms, for instance, I think as far as I'm aware, there are multiple different values which are driving this compatibility matching. So responsibility is one, level of compatibility between organ donors and recipients is another. Questions around fairness as well, about who should be prioritized as far as these this matching is concerned, separate from questions about responsibility. I think the idea is essentially that when you have this many different values which are driving treatment rankings, if you pick out one value and you want to tweak it for that in a different way, it causes a sort of dispersed effect that ripples out into how the ranking would have been produced actually if that value was configured in that different way. So I don't think computationally it's as simple as just saying, well, this person is responsible for their kidney deterioration, and so because of that, we are not going to we're going to remove him. Because if you remove him, it's not just that you just go to the next person, because I think if you remove that person, if you remove this person, the compatibility matching will might produce a very different list of rankings based on the remaining compatibility of different organ donors within the system. So that's the sense in which I think these tasks are computationally too intense for single humans or even teams of humans to do. And I think this has been proven over the last 10-15 years that these models ultimately generate much better resource allocation decisions than even if a team of humans were to try and do it themselves.
Thanks.
Owen, I think you next.
Yeah, thanks. Yeah, a lot too over there. The talk obviously went through a number of very interesting points. Yeah, I mean, thinking about a lot of things I could reflect on. One thing that jumped out at me was this discussion of materiality. This is something that we've been talking a lot about in Singapore due to various recent changes in the law relating to disclosure. And I guess maybe the way you're using materiality is a little different from the way I'm used to it, from the way it's kind of been been inundated with us recently. But it's one thing to say, well, this information would be material if the doctor just disclosed it, right? That's often when we talk about materiality. We have to, find out all these pieces of information to tell the patients so they can make a decision. But in this scenario, it's a very different context from that traditional literature on materiality, because this is a piece of information that just doesn't exist. The explanation, I'm presuming anyway, right? It's just not epistemically accessible, at least in the black box version of the AI, right? And typically, when you have that kind of information where, yeah, in theory, if it existed, you should tell the patient, but it just doesn't exist, right? Then it wouldn't really be triggered as part of an obligation of disclosure on the part of the physician or as part of a shared decision-making model, simply because, the odd implies can idea. You can't disclose this because it doesn't exist. So it's a different sort of thing where you're saying, well, actually, do we have an obligation to generate this information? And that's a very different sort of discussion. And I haven't seen that as much in relation to discussions of materiality, at least not at the individual, physician-patient level. Maybe there's some sort of systemic concern here. So I guess I wasn't certain, yeah, that if the literature on materiality, where it talks about what's relevant to this particular patient's decision, is going to be triggered here, because again, you can't, yeah, if the information doesn't exist, it won't trigger that responsibility of disclosure. But then you had this little bit at the end that talked about this survey. If you survey patients, you find out who really cares about explainability. I mean, is that supposed to be doing a lot of work? And what sort of work is that supposed to be doing in trying to understand whether or not patients really care about this? Like, is the idea that if it turns out X percentage really care about explainability, okay, does that mean that we really should be changing our models in order to meet the demand of X percentage? And so the challenge is both the X percentage is 5% or 10% or 20% or whatever. And there's other 90%, and maybe is their care going to be made worse because you pick an explainable model to meet that 5% or whatever demand. And I see where I'm going there. So I guess I didn't quite see where we would go in terms of some percentage caring about explainability to, well, we should change our models to meet this minority, I don't know, their demand, given that if this information doesn't exist, there's not even an obligation of disclosure in the first place.
Yeah, that's a good question. Thanks, Owen. I guess two thoughts about that. The first thought is that I understand where you're coming from, in the sense that if, for instance, these opaque models are being used and these explanations aren't even being produced in a way that can be consumed or communicated, then there is no packet of information that can be disclosed, and so is material in this case, because the only way something can be material is if it actually exists. And I guess what I see the enterprise over here, what I'm doing as, is sort of answering the question prior to that, which is, right now we're at this sort of decision point when it comes to the use of these models in healthcare, where in some cases these models are being deployed in completely opaque versions, whereas there are other places where people are doubling down and saying, no, we need interpretable models, and that's how we should be in critical domains like healthcare. And so I think here we have a question that needs to be answered about what sort of models should we really be trying to develop? So it's the question about materiality is not so much in the sense of these models are already out there. Can we even treat this information as material? But it's more in the sense of assuming that we could have black box models, or assuming that we could have transparent or interpretable models, and with these two versions of models that can exist and all the relevant information that each of these models that can provide, in that collective set of information, which information might be material and which might not be. And I think if we can figure that out, if we can figure out to what extent, say, interpretable models might provide information that is more material versus black box models, we can then make a decision about which sorts of models to develop, in a way that best allows for autonomous patient participation in a way that best serves shared decision making. So I see the question here that I'm answering as one which is prior to the kinds of decisions that the medical law sort of examples that you're talking about are really concerned with. So that's one thing. As far as the empirical bit, I'm not sure. I'm not sure what the threshold should be. I'm not sure to what extent it should drive a selection of one type of model over another. The only point that I was trying to make there was that if we accept the characterization in the literature that for information to be material, it just needs to be seen as material rather than being causally involved in the patient's decision making, then really it's about what sorts of information that patients see as material. And that's something which is an empirical question. But I mean, we can think about this. We can think about what happens if 20% of patients say that they see medical explanations as material, and 80% say that either they don't see it as material or is substitutable by statistical explanations or best guess explanations. I don't know. I guess I'll ask the question to you. What does empirical bioethics say on this, right? Maybe Mikey should weigh in on this as well, right? Because under such divisions of public sentiment, do you just go with, what even a minority of people might say just so that they're being served as well? I guess we're also talking about it very cleanly, right? If there is a trade-off between accuracy and interpretability, we won't be able to, in practice, bracket off questions around how well epistemic ends are met and how well questions around responsibility are met. So I take on board your point. I think it's a very important point. I just don't have an answer to it. And I think when we factor in other desiderata based on which these models are selected or would be seen as important, I think it just complicates it even further.
Maybe Mike can weigh in on that and any other questions that you might want to ask.
Thank you. Yeah, well, I don't have much to say about that other than I wouldn't just endorse the idea that the majority view should be the one we put forward. I think that would be deeply problematic from an empirical bioethics position. But my points, I have 2 points as well, Abhishek. I thought it was a really interesting talk, and I thought we were very careful in the way you argued against standard moral panic views that people have sometimes about these new technologies. I want to pick up on the first point, which is about the medical explanation. I think it's very much the sort of development of Julian's first point. And I worry about, again, this idea of concern coming from medical ethics, which is really about sort of over-demandingness placed upon the AI context as opposed to the non-AI context in decision-making, because it seems obvious to me that for most of the time, a doctor will not be able to give an explanation of the reasons why they take a view about the force of the evidence behind their views, their expertise around clinical outcomes. They won't be able to marshal and explain how different sources of evidence factor into their view. They won't be able to track back to the gold standard RCT and work out what the primary outcome measure is and see how that might fit or might not fit their own views about the evidence. So, I mean, you might object and say, well, but at least you can find out about it. There isn't a black box. There is an evidence base. To all intents and purposes, at the bedside, that's not going to be explainable. And so if we're worried about the AI context, in the day-to-day practice of medicine, we're also going to be equally worried about everything that goes on right now. And it looks like most of the time we're going to fail on that account, it seems to me. Not all the time, but most of the time. So I do worry a bit about taking this as a special case, when actually many of those same objections seem to me to apply in the ways in which evidence is marshaled in the background by doctors now at the bedside. So I think that's a kind of reiteration of what Julian started with. My second point is about your part 2 of your talk, where you talked about the kind of form of shared decision making and its ethical foundation. So I'm always a bit skeptical of thinking that shared decision making is solely about respect for patient autonomy. And in fact, we're talking about shared decisions, firstly, suggests it can't only be about autonomy, because that wouldn't make much sense. And I think that those differentiated models, I think you handled really well. I do agree that they differentiated in kind of the practice of what it means to decide, but I don't think they're all about respect for autonomy. I think if you take something like the deliberative model, which I think is perhaps the most persuasive kind of shared decision making, one way of understanding that is not that this is the mechanism through which we best respect patients' autonomy. We might say, look, this is a set of interactive discussion-based requirements in which patients can participate in trade-offs between competing values, including the value of their decision being respected, but also that they can marshal the obligation that the doctor has to act in their best interests, for example. So it's a way in which, you know, those differential values that underpin good practice in medicine can be brought to the patient's table and worked through in a deliberative exchange. So it's partly about patient autonomy, but it's just as much about the doctor having a space in which they can talk with the patient about their other obligations to act in their interests. And that gets us to a slightly different position, but it also suggests that the sort of patient autonomy account of shared decision making is not necessarily as straightforward as it might first appear. And I have to say, I think those differences between the different models just point towards a different ethical foundation as much as they do towards different practices. I'm interested to see what you think about that.
Yeah, so about your second point first, it's very interesting. When I was reading all the different accounts of patient-centered medicine and shared decision-making and X and Y and all these different permutations of this from the 70s and 80s, it seemed that it started off from a very specific problem, which is paternalism. And then it sort of just developed from there. And most of it was in response to this idea of paternalism, where doctors would just specify what values patients should be making their decisions based on and what their decision should be, and patients were just supposed to accept that. And the idea was that, yes, that's not exactly right. Patients should have a say in their own decisions, in the medical decisions concerning them, because that's where the autonomous action comes in, right? You want patients to make decisions, or you want patients to live with decisions that they have made themselves. And so from this paternalistic model, you swung to the other end, which was this informed model, right? Which was that doctors provide the medical expertise and patients assimilate that with their knowledge of their own preferences and values, and they sort of move forward with that. But then there was a problem with how it was actually in practice, right? Because patients don't arrive to the clinical encounter with their values and preferences neatly packaged and ready to be used for the clinical decision to be made. These values and preferences are difficult. They require reconstruction. Sometimes they require construction for the first time. And this is something in which they might not have much experience, because this is presumably the first or one of the first times they found themselves in that situation. Whereas the idea is that the doctor might have found himself or herself in that situation multiple times. So you move from the informed model to the interpretive model, which is that the doctor helps to help the patient figure out what their values and preferences are for this particular decision in question. But then there's a further question of like, well, is that really all the doctor's role should be? Because there are some people, like for instance, Ezekiel Emanuel, for instance, who seems to think that, oh, the doctor really needs to also stay true to the values of the medical profession that he himself has been communicating and has been battling for over all this time. So it's not okay if a patient comes in and says, you know, I want to continue smoking, or I want to continue eating, high cholesterol food, because that's just what I think my ends are. The doctor should be able to push back against it and say, well, maybe you should consider not smoking because this is not something which is good for you, right? There are certain health values which perhaps, accommodate the doctor providing a contrasting value, right? Or maybe the way to think about it is that when the doctor pushes back, he is in fact allowing the patient to better harmonize across the set of all of his other values as well, right? So that's when you move from the interpretive model to the deliberative model, right? So I guess what I mean to say with all of this is that it still seems to me to be primarily about autonomy. It's just about how that autonomy manifests in practice, because you have all these other different considerations and complexities in the clinical encounter that need to be navigated. That being said, I do think there are some cases in which autonomy is not the only grounding value, and I think I made a reference to that in the presentation when I said that that was precisely what the not causally important bit of the information was about, because it seems like it's not going to make the patient make any better decisions about how they want to live their life or what kind of medical decision they want to receive, but it's just something about their level of comfort and their level of openness to the medical encounter. And this is where you have all these broader conceptions of shared decision making that come in, where it's more about the affective state of the patient in the clinical setting and how they come away from it, whether they have regrets about information that they should have received, even if they wouldn't have used it in any different way. So I do think I agree with you that under more recent broader conceptions of shared decision making, you won't have just autonomy, or maybe you have a more expansive idea of autonomy that isn't just about options and how to reason over them. I haven't really found anything which really lays this out in a very proper way, though, in terms of what are these other values. And if you have any recommendations on that, I'll be happy to use that and factor that in. But my sense of it so far is that it's still primarily about autonomy with a little bit of like patient affective state and mixed into it. I'm not sure if that answers your question.
Yeah, it does. No, it does. Thanks. I think that is the key question for me, whether it's about a more sophisticated, richer account of autonomy, or whether it's about other values where equal partners come together in an evaluative exchange for decision making. I think that's where the action is in that distinction.
Maybe we can have one final question from Pete and then wrap up.
Great. Can you all hear me? Yeah. All right. Great. Thanks for a great talk, Abby. I wanted to pick up on the conversation on materiality. So for the medical explanation challenge, you mentioned the case where information that patients seek might be material, even though it has no causal impact. And that information was considered material simply because the patients themselves considered it so. So in my area of research, prenatal testing, there are empirical data showing that pregnant women sometimes seek information about how prenatal technologies function. Although studies have also shown that the patients possessing this information doesn't actually affect the level of informativeness when making decisions. So it just seems that sometimes patients have a curiosity and they want to know facts about the technologies they use. So my question is, do you think that certain AI models are best placed to accommodate the provision of objectively non-material knowledge that has been deemed material by the patients themselves? So perhaps an interpretive model can provide these explanations to patients in general, but would that model get at the type of seemingly random information that patients sometimes seek that they deem as material, but don't typically arise in a clinical consultation?
Yeah, I think so. So I think that that's the strength of like interpretive models in general. And I think that's also the strength of models which explain the primary model from sort of an exogenous point of view, which is that you have these medical explanations that are provided, which the patients can then use to satisfy their curiosity, even if it doesn't actually make a difference to their decision making. So it's interesting that you say that in prenatal testing, like patients actually do want to figure out how these tests medically are done, and the sort of medical and technical aspects of the test as well. I think it's really about, I think where the rubber really meets the road is about, empirically, what is it that for a particular medical decision patients consider material. And I think if I were to, and I think interpretable models and explainable models would help. But I'm also wondering how you want to ask the patients about what information they would consider material. So you could ask them, if we provided you with this medical explanation, do you think this is important information? And my gut is that they'll probably say, yes, this is important information. I wish I had that information. But then maybe you could have two randomized groups of patients. And for one group of patients, you could provide them with information that an interpretable or explainable model would give them, including the medical explanation. And in the other model, you could give them a black box, all the statistical information that a black box model would give them, and also maybe a best guess explanation. And in both cases, you could ask the patient, do you feel like you received all information that you feel is material to your decision? Now, in that sort of situation, I'm not sure which way they would go. Perhaps, if I'm being honest, maybe they might still ask for medical explanation and they might still favor the interpretable model, but I'm not 100% sure. And I think you really need the empirical work for that to be the case. So if you could send me any empirical work you found on this, that'd be super helpful.
Yeah, absolutely. Thanks.
If there are no more questions, thank you everyone for joining us today. Thank you, Abhishek, for such a wonderful, robust discussion and presentation. So yeah, thank you all for joining us. Hope to see you all again at another Journal Club session. Thank you so much and have a good week.
Thank you, Mathavi. Thanks, everyone.